started.
Hip flexion. All right, so you're going to have the patient lie down on their back. You're going to stabilize the... So let's just talk about how they do it in research-based, right? So research-based, they would have you, the patient in this position, they would have a mulligan belt like across the, just above the ASIS to stabilize the pelvis. In clinical practice, by all means, you can certainly do that. I have opted not to do that just because of the time constraints and also people, I think it's really just time constraints. I don't really care about the patient's perception. So usually what I'm going to do is I'm going to use a C grip around the ASIS and the PSIS. So thumb on ASIS, index finger around the iliac crest. The other leg is actually going to be your tail. So when it rolls out or this opposite thigh flexes, it tells me that the pelvis has moved in some manner. As such, it would be good practice to establish that. And so though the patient is somewhat engaged, I don't see it negatively influencing the testing hip. The other thing is that sometimes when people get on the table and they're like this already, so it's also good practice to have them bridge first. So let's do that. So you bend both knees, you bridge up, they come back down, you pull them long, and then you would cue them to keep your foot just like this, toe pointed up, back of thigh pointed down. That should help them, that should reflexively cause them to stabilize a little bit on the posterior chain of that side. Okay, I come up with my C grip, I kind of cradle the legs so they feel supported, and then I'm going to gradually try and bring the thigh to the shoulder, to the clavicle. What you'll see in some restricted hips is they'll just, don't force the hip where it doesn't want to go, just see what it does. Because some of the people will just wing out. So that's like, I'm getting some tissue resistance or some type of resistance. It could be on your clothing. What do you feel?
Maybe it's my belt.
Can I keep going?
Yeah.
I don't know. I'd say because that there is like where your foot's rocking. Yeah. So at this point, I ask the patient to hold underneath their thigh. I don't use an electronic bony for this one. I just have it to be, like when I use it on the top of the thigh, based off like the convexity or lack thereof of their quadricep, that can negatively influence it from one person to the next. Within a particular person, depending on what their rehab is and how much hypertrophy they're going to get over the course of time, that could also be influence. That could also influence it. You could take the bisection here with your phone. That would be another option. Typically, I'm going to go right at the greater trochanter with my traditional goni. The axis of the goni is lined up directly at the greater trochanter. Yep. And then the distal arm of the goniometer is right to the femoral condyle. And you're looking for at least 120 would be a healthy hip. Right now we have 110. And then you come back down. So that would be your hip flex. Any questions or thoughts there?
I feel like I probably could have gone. I don't know. It's tough because I'm like, I feel like I could have even like pushed it even further. With like if I try to stabilize my pelvis, instantly rotate, and then like actively did that, I feel like I could get like sure that's uncomfortable, but like.
Yeah, I don't know. When you do that, I feel like that. Yeah. I'd say you've blown past your hip. I'd say you're getting the posterior
pelvic.
Yeah.
Okay. Yeah. All right. Sweet. Yeah, I see what you mean.
So again, it has the capacity to get further, but it's it's no longer your hip, right? And that's something that you're going to want to, I find to be valuable. Maybe you look at it more functionally when they get some degrees of freedom from some of the adjacent body regions, lumbar spine. I can't really say that the ilium makes any meaningful contributions.
Yeah.
Others would see it differently. All right, so we'll pause that video, and then we will